Okay, if you're watching this, it means that I successfully mastered posting a PowerPoint with an embedded video. The way it looks right now is that this is going to be on YouTube. I posted a video for the other class last night. It looks like it's working. I'm going to do the same thing with this video when it's complete. Unfortunately, I can't post the video, the PowerPoint with an embedded video directly to Moodle because the file size is too large. So what I'm going to do is I'm going to post on Moodle a hyperlink to YouTube, to the video on YouTube, and I'll also post the PowerPoint independent of the embedded lecture. So you'll actually have two files, or a link and a file on Moodle. Well, you know that if you're watching this. I will also, I'm looking at doing the exam next week. That will be delivered electronically via Moodle once I figure out how exactly to do that. Other than it being delivered electronically, it'll be exactly like a regular exam in terms of the types of questions, the number of questions, the content, all that kind of stuff. You'll have a 2.5-hour period, just like in class, to complete the exam, which should be more than enough time for everybody. And I think the one thing that'll be different, obviously, is that there's not a particular time that you have to take it. I believe I'll probably give you a good 5-day to 7-day window where you can choose to take it when you want to take it. I think the only caveat with all that is once you start taking it, you have to complete it. You can't stop it and come back to it later. But I will send an email and maybe a video clarifying all of that next week when I get ready to post the exam for you. I'll let you know. Otherwise, I'll apologize in advance. We're going to give this a shot. I hate this. I would much rather be standing in front of you, talking to you. This feels a whole lot more like talking at you, even than the worst of the lectures during class periods. So we'll give it a shot. I am going to make it considerably shorter than I would in class, simply because I know that this is difficult for everybody, and sitting and watching a YouTube video, even one as delightful as this, is not anybody's idea of fun. So I'm not going to spend a lot of time talking to you about the basics. I'm not going to do a long review for you about classical conditioning, operant conditioning, observational learning, that sort of thing, simply because the book covers it and covers it quite well. So review the book. I will include questions on the exam about the basics of learning theory, just like I'm including basic questions on the exam about psychoanalytic theory. You want to make sure that you're familiar with the basic vocabulary of classical conditioning. Again, I'm not going to spend a bunch of time talking about this specific vocabulary. It's pretty straightforward. I would assume all of you have had it, at least in introductory psychology, if not an actual learning theory class or something similar. Don't have much to say about this in terms of the concepts themselves or the vocabulary itself, although primarily what we're going to talk about today is how do we use this in terms of actually helping somebody, in terms of doing behavior therapy. Okay, so just make sure that you have reviewed the book and reviewed the vocabulary. Regarding the application of learning theory in behavior therapy, the big thing that should jump out to you about behavior therapy in actual practice is that it is significantly more active and directive than the other approaches that we've talked about so far. the analytic and existential and even the humanistic approaches, I guess it would be a fair thing to say that they're more art and perhaps at times less science, whereas behavior therapy is very much grounded in empirically supported intervention. The approaches that behavior therapy uses are things that have been demonstrated very well. In fact, they grow out of research generally. There's a problem, somebody looks at interventions for addressing that problem. Once the interventions have been identified, they are disseminated across the field and people begin using them. The upside and the downside of this is that it's very methodical. The downside of that, of course, being that there are some kinds of problems for which behavioral approaches are a little less effective. If you have somebody who is having an existential crisis, say, for example, a crisis of meaning, they feel empty and lost in their lives. Their heart is broken by grief or by some other loss. I won't go so far as to say that behavior therapy has nothing to offer, because of course there are always things that you can do. There's action you can take that will help mitigate grief, that will help mitigate some of the anhedonia and dysphoria that's associated with existential despair. But the behavior therapy is just that. It's focused on behavior. It's not concerned primarily with the seeking of meaning and understanding of one's internal life. That's the ground of the insight-oriented psychotherapies that we've already covered. That, to whatever degree that's a shortcoming, you can have a debate. The obvious strength of behavior therapy is that it's very pragmatic, it's very focused. If you come in and you have, say, a phobia, if you have problems with compulsive behavior associated with obsessive compulsive disorder, behavior therapy is a very strong intervention. It works very well, and it works pretty quickly. Additionally, it's a bit more no-nonsense, I guess you could say, than the insight-oriented approaches, in the sense that many of the things that behavior therapy is best suited for, it isn't a question of whether behavior therapy will work. It's a matter of, are you sufficiently investing in yourself? Are you following the instructions? Are you doing your homework? Are you doing the things that the therapist is laying out for you? Properly implemented behavior therapy is actually really very, very effective for the problem areas that they've been demonstrated to work for. It is very measurement focused. The behavioral approaches spend quite a bit of time asking people to monitor and document their behavior. It places a heavy premium on homework, asking people to actually go home and be accountable for doing certain things, behaving in certain ways. And actually, I would say that is a strength of behavior therapy from which the insight-oriented therapies have learned. The reality is, if you send somebody home to do homework, what you essentially are doing is asking them to expand the therapy itself outside of the therapy room. So they come in and they see you once a week for an hour, or once every 2 weeks for an hour. By giving homework, what you're doing is preventing the person from leaving the therapy in the therapy room during the therapy hour. You're asking them to take it home and take it out, so to speak, and think about it and focus on it and work on it in between sessions. This is quite important. If you have a substantial life problem that has taken perhaps years to develop, it's I guess I could say it's outrageous to expect a problem that's been there for 15 years to be addressed by an hour of therapy once a week or once every other week for 6 months. That's simply not a realistic expectation. To whatever degree psychotherapy, whether it's insight-oriented psychotherapy or otherwise, to whatever degree the psychotherapy works, it works because the person has taken responsibility for implementing change, for behaving differently outside the psychotherapy. That behavior, that change in behavior may be the result of things that they learn about themselves in the therapy, but if you aren't actually initiating change outside the psychotherapy, then the psychotherapy might be interesting, it might be gratifying or cathartic, but it's not necessarily going to be particularly productive. So that use of homework in between sessions is an excellent feature of the behavior therapy. Part of that homework is tracking, documenting what you're doing, how much time you're spending doing it, that sort of thing. The behavior therapy also spends a fair amount of time documenting, not just at intake, but intermittently throughout the therapy itself and at the conclusion of therapy, and sometimes even afterwards at a month follow-up or 6-month follow-up, what the symptoms look like. This is helpful not just because it allows you to determine whether or not the therapy is helping, but it's also good for the patient, because one of the things that you sometimes see happening in psychotherapy is they'll come in, and we talked about this earlier in the semester, people tend to get a fairly strong benefit from the first session or two, if for no other reason than they're actually taking things into their own hands in terms of beginning psychotherapy and doing something about the problem. That in and of itself, even if you've not otherwise intervened, tends to help. And of course, one of the things that we always want to make sure we're doing in the first couple of sessions is taking some sort of concrete action to help the person make a positive change. So you generally will get some fairly significant improvement over the course of the first 2 or 3 sessions. And it's not unusual then for it to kind of level off and stabilize. And in other words, you don't get a steady upward trend in the person's subjective sense of improvement, but you get a little jump, and then oftentimes it'll kind of stabilize, or sometimes even regress a little bit. You can get to the point where the person feels like nothing has changed, and it is always helpful to be able to sit down and say to them, well, hey, you filled this out for me, this PHQ-9, the depression screen that we talked about earlier in the semester, or a Beck depression inventory or a Beck anxiety inventory, and this is the score you produced at intake. You did it today, and this is the score you produced. So you still are looking better. Hopefully, that's what you're telling them. You're still reporting that you're feeling better, even if perhaps how badly they were suffering is now a bit of a distant memory. So keeping evaluating, even on an every session basis, where they are today, formally evaluating that with a screening device like a PHQ-9 or a Beck can be helpful. It also gives you a jumping off point for talking about, okay, you're not doing as well this week. What's going on? Your score went up. Usually depression or anxiety or whatever intensifying is reflected by a higher score on these screeners. Your score went up. What's going on? What do you have any sense of what it was that contributed to this? Some things that behavior therapy is doing quite right. historically, one of the things that could be a shortcoming for behavior therapy is that it was quite rigid, and it restricted itself just to behavior. Now, in some circumstances, that's fine. It works really well, but you can see how that would be limiting. Say, for example, if you do have somebody come in and they're grieving, they lost their spouse or a parent, or God forbid, a child. And the behavior therapist, the old-fashioned behavior therapist, it gets very focused on increasing physical activity, working on sleep hygiene so that you get the person sleeping better, working on their diet, these kinds of things. Nothing wrong with that. In fact, those are good interventions in that situation. Increasing social activity, and the person might be completely compliant with it and might almost certainly will benefit from making those changes. But one of the things that's characteristic when you've lost somebody you love is that it needs to be talked through. Part of recovering from grief is processing that grief. And that is one of the concessions that behavior therapy has gotten better and better at making over the last couple of decades. So much so that now some of the lines between behavior therapy and other approaches really have blurred a good bit, even to the point that they're much more cognizant of cognition. They're much more willing to work in ways that are beginning to look cognitive behavioral, which we'll talk about after the exam. They're much more willing to look at things that are not strictly behavior, but are instead about emotion and cognition. Okay, so a person comes to you for psychotherapy, and you're a behavioral therapist. After the initial paperwork, the initial interview about what exactly the problem is, what exactly is going on recently, you complete all of the informed consent paperwork and all the things that are involved in that first session, perhaps session and a half. What then do you do in behavior therapy? What looks different in behavior therapy from person-centered or existential approaches? Probably the most prominent point of departure would be what we call the functional assessment. And functional assessment is basically just a very methodical investigation of what exactly is going on. It's looking at the behaviors that are being demonstrated by the person and what function or purpose those behaviors are serving for them. The premise in behavior therapy is that whatever the person is doing, no matter how outrageous, it serves a purpose. I'll give you an example of something that we found ourselves confronting with when I was working on an inpatient unit with people with severe autism who came to the unit because they were behaviorally unmanageable elsewhere. So in other words, they generally speaking, they came from other residential settings or inpatient settings where they were too aggressive or otherwise disruptive to be managed. It was pretty rare for them to come from somebody's home simply because we were kind of the final step as opposed to the first step. Somebody's unmanageable in the home, they would go to a lower level residential setting. If they had failed there, they might move up a level. And generally the program that I was working with, it was a neurodevelopmental institute. And we were basically getting the worst of the worst. And one of these worst of the worst, so to speak, people was a boy of about 16 years old. He was nonverbal, had pretty severe classic autism, was nonverbal, and was a big boy. And when I say a big boy, I'm talking about he was probably a good 270 pounds, maybe a little bit taller than I am. And one of the things that had led to him coming into our program was the fact that he would, I won't say inevitably, but very frequently lash out at people with his hands generally open, lashing out toward their faces. And because of his size and because of the fact that he really did not like having somebody cut his fingernails, this lashing out caused a lot of injury among the people who were trying to care for him, injury to his family, sometimes even like strangers when they tried to take him out into the community, strangers at the grocery store, that sort of thing. Well, as an example of this idea that all behavior is purposeful, all behavior serves a function, the presumption that we were making with the functional assessment there is that this is not random. It's not just aggressiveness. There's no such thing as just aggressiveness. Aggressiveness itself is serving a purpose. What purpose is it serving? Well, and in the case of this, I want to call it reaching out, because it turned out that's actually exactly what it was by this young man. It was his effort. One of the misconceptions that we have often of people with autism is that they do not desire emotional intimacy or relational intimacy. And in fact, that's completely wrong. In fact, one of the things that you see with people on the autistic spectrum is they're often very lonely. Their tolerance for emotional intimacy and relationship intimacy is different from other people, but it doesn't mean that they don't want it or need it. And essentially what was happening in this case is that this was a boy who very much wanted to make contact with other people, wanted to interact with them, and had no idea how. Just on a social cueing basis, had no idea how, but also had a lot of difficulty in terms of proprioception, in terms of kind of knowing his body, knowing how to control his body in space, knowing being able to control how hard he was grabbing a hold of something, these kinds of things. Just neurologically, he was having a lot of difficulty being aware of his body and controlling his body. So it wasn't necessarily that he was reaching out and trying to hurt you. It was that he was having difficulty gauging how he was reaching out, essentially. Once we figured out that this was in fact not intended as aggression, apparently, but was intended instead as a way of connecting with people, we could be more proactive, and we could do some things in terms of teaching him how to interact with others, and teaching others initially, the people who are around him, the staff people and so forth, how to preempt the behavior by reaching out to him. And within just a couple of days, a week at the most, the behavior was largely eliminated. But again, it was figuring out why that behavior was being caused, or where it was coming from. The way that this functional assessment proceeds is very much, and this is not a surprise with behavior therapy, it's very step by step. It's very operationalized, very methodical. And it's based on something we call the ABC model, which is looking at the antecedents to the behavior. What are the things that are causing the behavior? What exactly is the behavior itself? And then what's happening afterwards in terms of the consequences of the behavior, reinforcement of the behavior or punishment of the behavior. So this ABC model is the basis for a functional assessment. Antecedents, behavior, consequences. This is the foundation of what we're going to produce when we do a functional assessment, which is simply just the step-by-step process of figuring that ABC stuff out. Generally, you see functional assessments on a formal basis used as part of an individualized education plan in schools where somebody has some sort of different learning needs, somebody's having some behavioral problems. You see it in residential facilities and inpatient psychiatric facilities, especially where they're dealing with more severe psychiatric problems. And then, of course, used by behavior specialists, behavior analysts, who work not infrequently with things like autism, both inpatient, residential, and outpatient on those bases. One of the things that's very useful about these functional assessments, especially in residential or inpatient settings, or in settings where somebody, as in the case with somebody on the autistic spectrum, on the more severe end of the autistic spectrum, is being cared for, like say in a group home, any of these settings where you have multiple staff members, or say maybe multiple family members, or multiple members of an education team, part of the advantage of a functional assessment of behavior is you can disseminate to all these people a common understanding of what's going on with the behavior. Hopefully it's accurate. What's going on with the behavior, and how to respond to it. So you get consistency across personnel, and in some cases across settings. So this functional assessment, it is basically a four-step process. The first thing we got to do is we got to figure out exactly what the behavior problem is. Then we collect information, analyze what exactly is going on as a result of the behavior. We develop a theory about what's driving the behavior, what's reinforcing it, and then we lay out a plan for how to eliminate or reduce the problematic part of the behavior, and preferably to replace it with an alternative behavior. So the step one, defining the problem behavior. What we are wanting to do is essentially to operationally define whatever the behavior is. I not infrequently would find myself when I was working with people with autism, I would go into schools, say, and I would have a parapro or sometimes teachers talk about problem behaviors from a kid, acting out, misbehaving, throwing fits, these kinds of things. And the assumption was that you knew exactly what he or she was talking about, but from the behavioral therapy perspective, that's completely inadequate. Well, what we want to do is we want to get as specific as possible. We want to know exactly when somebody's, oh, well, he's misbehaving, what exactly does the misbehavior look like? Physically, what does it actually literally look like? What movements is the person making? What is observable? What is measurable? Not infrequently, we would ask them to actually try to get on video, or at least on audio, whatever the problem behavior is. Say somebody's becoming violent in the classroom. We want to see the violent behavior. And ideally, what we want to see is not just the violent behavior itself, but some of what was going on prior to the behavior. We want to begin to get some idea, because it's going to help us when we try to figure out where the behavior is coming from. We want to get an idea what preceded the behavior. But we need to know exactly what is going on with the behavior. Going back to the example I just was giving you a few minutes ago about the boy who was assaulting people by reaching out. The reality is he wasn't wasn't swinging at people. He was reaching out with open hands. In fact, that was often part of the problem because he was poking people in the eye and scratching their faces and stuff like that. And now he was doing it in a way that looked really aggressive, but it mattered that it was consistently with an open hand, and it was consistently, people would say it was unprovoked. He didn't appear to be angry. There was not anything unusual going on in the environment beforehand. There wasn't a particular kind of person he would do this to. He was doing it across all sorts of situations. Anyway, all of these details, when we started looking at exactly what was going on very specifically and in some detail about the behavior, it became more and more apparent this doesn't look like violence. It doesn't look like aggression coming from anger or aggression coming from fear. There wasn't any evidence of a fearful or an angry situation there. So that was an example of how it helped to really get a concrete description, or in our case, to have it done to us, because of course that happened almost immediately when we met him, is he would do exactly this same thing to whoever was meeting him, including me. The other piece of this is that we want to get a sense of, are we dealing with one behavior or several different behaviors? One of the things you sometimes find out is that when you start getting objective about it and you start getting very, very specific and very detailed about it, what you find out is that what the misbehavior isn't one thing, it's 3 or 4 different distinct behaviors that each have to be addressed individually because they're not all coming from the same source. They're all not all being precipitated by the same needs. Okay, so once we have a good detailed picture of what exactly is going on with the behavior, what exactly the behavior looks like, we want to analyze the situation. We want to get an idea of the context in which the behavior is occurring. This process is very thorough and very methodical. It is looking at not just where the behavior happens, but where the behavior doesn't happen. How long is the behavior continuing? Is there anything in particular that is correlated with the end of the behavior? Are there things that are correlated with the beginning of the behavior, things that appear to be precipitating it? What's the situation in terms of the relational context? Does it tend to happen in crowded situations? Does it tend to happen when the person is alone or just with a few people? Alone, for example, one of the things that you'll sometimes get is intentional self-harm. And one of the things that you not infrequently will find with intentional self-harm is that it tends to occur when nobody else is around. And so one of the real easy ways of reducing intentional self-harm, we're talking about things like cutting, is especially if the person who is cutting him or herself no longer wants to cut him or herself and is willing to cooperate, it becomes actually fairly easy, at least in the short term, to eliminate the behavior just by simply reducing alone time, especially if the person can cue others that, I'm having an urge to cut and I need to be with somebody right now. So sometimes finding out the kind of the contextual details of the behavior really can make a difference in terms of eliminating it or controlling it. We want to know the people that are around. Is there, one of the things we would see not infrequently with when we were working with kids with autism is that there were certain staff members who, for whatever reason, were very calming for the person. And if so-and-so, a staff person, was around, you could bet that the acting out was going to diminish in frequency and intensity. On the other hand, sometimes you have people that pretty much guarantee that there's going to be increased agitation when they're around. You know, that particular teacher who for some reason provokes anger and hostility from students, or tends to be associated, maybe they aren't provoking it, but tends to be associated with anger and hostility. And we want to make sure we're paying attention to the sex. You know, is the person acting out predominantly with males or females? Does the sex of the people around them tend to make any difference at all? Age, same thing. All these kinds of details. What we're doing is we're looking for patterns. We're looking for clues as to what might be precipitating, exacerbating, reducing the intensity of whatever the behaviors. If the person is somebody who is able to communicate effectively with us, we want to do an interview with the person about how are you feeling? What do you have anything that tells you that the behavior is coming on? Again, a good example of this would be somebody who's wrestling with self-harmful behavior. You know, do they have cues? Do they have something that tells them that this urge is coming on them? How do you feel during the behavior? How do you feel after the behavior? And how a person feels is one of the consequences of the behavior. And if we can begin to change how the person feels as a result of the behavior, especially if we can make the behavior somehow toxic for them, somehow unpleasant for them, we might be able to reduce the frequency and intensity of the behavior itself. And very important, this is especially the case working with kids, can we identify an alternative, more desirable behavior? You know, this is kind of the old, if you got if you're responsible for a bunch of little kids and they're raising hell and acting the fool, one of the nice easy tricks is coloring. They're running around like little banshees, and you get your coloring crayons out and you call them all together and you get them seated down at the table and you give them an assignment of, I want you to draw me a picture of the jungle, or I want to draw me a picture of what you want your house to look like when you're a grown-up. And then of course once they quiet down, which they almost inevitably will do, the vast majority of kids, and they get to work with the crayons, you reinforce that replacement behavior. You didn't want them being loud and noisy. You do want them being quiet. The coloring got them quiet. Now that you got that quiet, reinforce the quiet. Pat them on the back, be real impressed with how quiet they're being and how hard they're working, this sort of thing. We're substituting an alternative behavior. We also want to look at, does the patient have control? Does the patient want control over the behavior? In most cases, the person does want control. They do want, generally speaking, especially if the behavior is causing a lot of problems in their lives, ultimately they very frequently would like to control the behavior. You often run into situations where the person has essentially despaired of controlling the behavior. They don't believe that they can get control over it, or this is one of the things that frequently causes trouble. They have been so closely identified with the problem behavior for so long that it has become, that they've become identified with it. It becomes part of kind of their image of who they are. And so sometimes you have the problem of beginning to separate out from the individual the behavior itself. And I can't tell you the number of times in working with kids with autism and working with people with cognitive disabilities that we had to really focus with the staff. And this works also in parenting. If you have a problem behavior, emphasizing to the kid, to the resident, to the patient, I like you or I love you. I don't like or I don't love the behavior. I have a problem with this behavior. I don't like this behavior, but I do like you. Where you're beginning to create that, you're helping the kid or the patient or the resident make a distinction between the behavior and their identity. And you're making a distinction between how you feel about the patient and how you feel about his or her behavior. That distinction isn't important just for the patient. Sometimes it's important for for the individual, the teacher, the staff person, having the teacher make that point, say to a problem kid in the classroom, the kid who's disrupting the class by acting out and throwing things and so forth. When the teacher intervenes with the kid, having the teacher draw the distinction between, I like you, you're a decent kid, I cannot stand this behavior because it's disruptive to my classroom. That can frequently reduce the intensity of the confrontation, simply because it makes it less likely the kid is going to feel personally attacked. It's also beginning to establish some hopefully we're establishing some sense of it's you and me against the behavior, in terms of actually implementing behavioral change with kids, with people who are seriously mentally ill, people who have autism or a cognitive disability, making it very concrete that I like you, but I don't like the behavior, is a big step in the right direction. And it's a big step toward enlisting the patient's cooperation in terms of wanting to change the behavior. And then step 3, once we've identified in detail what exactly the behavior is, and we've done our ABC thing, we've identified the antecedents and the consequences of this behavior, we want to begin to identify some theories about where the behavior is coming from. And this is why you're taking all the classes, right? This is where knowing developmental theory and knowing like the analytic theories about defense mechanisms and all that kind of stuff, knowing some sociology, doing reading, reading great literature and learning about what makes people tick, because you can learn as much from great literature, heck, from movies, as you can sometimes from the writings of psychologists. You can learn a tremendous amount from philosophers. Knowing your biology, knowing the way the body works and the way the brain works. These are the fields of study that allow you to develop useful theories about where the behavior is coming from. I'll give you what I think is a good example of all of this. I had a kid, first grader, who he was at the high end of the autism spectrum. First grade, was in some special education classes, and was brought in by his mom because on entering first grade, within just a couple of weeks of getting into first grade, he started becoming fairly suddenly and intensely aggressive in the classroom toward both the teachers and fellow students. And it was fairly dramatic stuff. I mean, a little boy who had never been aggressive, according to the parents, at all in his life, was hitting and kicking and scratching, and in one case even biting bit another student. We absolutely banged our heads against the wall for a long time with this. We did a fairly thorough functional assessment. Got absolutely nowhere. I was seeing him on an outpatient basis, so his mom was bringing him to my office once a week, and we had probably been meeting for probably 3 or 4 weeks when I finally kind of resigned myself to the fact that I'm actually going to have to go look at this, and ended up going over to the school one day to watch the boy. And I got there before school started and was talking to his teacher. We're standing inside. This was in Michigan in the wintertime, so we were standing inside waiting for the kids to come into the school, and the teacher says to me, "I think he's doing all this on purpose. I think he's being aggressive and he's planning it." And I said, well, why do you think that? And she said, "Well, here they come, look at him." And they're walking up the steps, him and a couple of the other kids that were in the class with him, and they're talking, and he looks pretty happy, and they're kind of chugging along, and they get to the top of the steps 5 or 6 feet from the doorway, and in the 5 or 6 feet that it took to get to the door, his whole face changed. He went from looking fairly relaxed and happy to looking like the Terminator, man. He got really grim and intense and even angry looking before he walked into the doors. And it was really perplexing. Nobody had mentioned this part before in the behavioral assessment. And frankly, I probably wouldn't have believed it unless I saw it myself. So I went in and I watched watched him in the hallway and watched him in the classroom for the morning, and saw a couple of periods of acting out. Had the first period of acting out, removed him from the classroom, got him calmed down by walking him outside, actually. Brought him back in within probably an hour or so. He had another less aggressive acting out, and he ended up sending him home from school. That had become the routine, is that he'd have 2 chances, and after the second chance, they would send him home for the day, because he actually he liked his classmates, he liked his teacher, according to him. I would love to tell you that I sat there in the school and figured out what it was, but I didn't. It was actually the mom that figured it out. She figured it out, came in to see me one day for one of our appointments a week or 2 later, and said he did it at Walmart. And this was remarkable because none of this had ever happened outside the classroom before. And she said, I can't believe it, he did it at Walmart. And we were talking about, what I was asking, doing all the functional assessment around the behavior at Walmart, what exactly did it look like? We were trying to compare it, make sure it looked the same as the behavior in the school. What was the antecedent? What were the consequences? What did you do after he did it? And, you could almost see the light bulb come on over her head. And she said, it's the lights. And I had no idea I thought she was talking about my office. But she said, no, it's the lights. There are fluorescent lights at the school, and there are fluorescent lights at Walmart. And for this little boy, there were no fluorescent lights anywhere else in his life. And it turned out that that's exactly what it was. It turned out that it was the sound that fluorescent lights make, which were it was like fingernails on a chalkboard to this little boy. And the thing is he wasn't even able to identify it until we sat him down and we talked to him about it, and we asked him, does the sound bother you? And at first he said no. This was in my office. And so we took him out of my office and we took him over to a bigger kind of a conference room in the building that did have fluorescent lights. So we walked into that room, and we sat him down at the desk, and we were talking to him, and he was coloring and everything. And then we went over and we turned on the fluorescent lights, and sure enough, you could watch the agitation increase the longer he sat there. And we played with the lights a couple of times and had him pay attention to it. And sure enough, he said, yeah, actually it does bother me. But it was so subtle, he never realized it previously. And of course, he's a 6-year-old kid, so he's not necessarily thinking in terms of analyzing the situation. And once we figured out what was driving the behavior, fluorescent lights, it was a fairly simple process. We made arrangements in the classroom to have the fluorescent lights turned off. We used some alternative means of lighting, and we worked with the little boy to help make him aware of this. He wanted to be a good boy. He was very clear about that. And so we developed some strategies for helping him control some of the agitation and tension that would arise as a result of this noxious stimuli, this really unpleasant sound that he was getting. So good example of kind of how this process, how subtle these things can be, and why a functional analysis becomes really important. I'm sorry, I kind of jumped the gun here in terms of talking about a behavior intervention plan that is based on the hypothesis. And part of the way you develop a behavior intervention plan, in the case that we were just talking about, is you play with the lights. You test your hypothesis. Is it the lights? Let's put him in a situation where there is no light. Let's put him in a situation where there is that fluorescent light. The next step with that kid was to put him in the classroom and have incandescent lights. eliminate the fluorescent lighting and watch what happens. And he had no problems. The other steps that are pertinent to an actual intervention plan, in addition to testing it out, is my theory about why this behavior is happening accurate, is identifying consequences, identifying effective punishments for discouraging the behavior, and reinforcement for encouraging an alternative preferred behavior. And making sure that we are using both positive and negative punishment and both positive and negative reinforcement. And if you don't remember the details about that, go back and look at the text. And I think I actually have that also on the slide, one of the earlier slides, making the distinction between positive and negative reinforcement, positive and negative punishment. But certainly using all four of your options there, or several of those four options, is more effective than just using positive reward and just using positive punishment. We want to make very clear, especially for people who are cooperative and want to eliminate the behavior, we want to enlist their help in identifying alternative desirable behaviors, and encourage their implementation of those alternative desired behaviors. And this is the case I've been talking mostly in terms of using a functional assessment and using a behavior plan to deal with problem behaviors among people who are compromised, people with cognitive disabilities, autistic spectrum diagnoses, and that kind of thing. But you can also do this on an outpatient basis with adults who are actually quite functional other than the problem behavior. Somebody who's a smoker. A functional behavioral analysis and a behavioral approach to smoking cessation is very, very effective. And one of the steps in that is helping the person identify alternatives to smoking. What else, that one of the things you commonly hear is that people, when they try to stop smoking, have a tremendous amount of anxiety and tension, periodically, usually corresponding to when they would like to take a smoke break throughout the day. And one of the things that increases the likelihood that smoking cessation is going to be successful is that you substitute for the smoking something that meets a similar need. I think I'm saying that right. I'll put it like this. One of the things you hear from people when they try to stop smoking is that I was doing okay until some stressor hit. I was doing okay until we were quarantined, and then I was just going nuts and I had to smoke. And they'll often report that they, corresponding to the smoking, they get a sense of relaxation and diminishment of tension. And it's often assumed that this diminishment of tension is because they're having some degree of withdrawal from nicotine. They give themselves some nicotine and they feel better. And certainly, in some cases, that's accurate. But the reality is, you get people reporting this even when they're on nicotine replacement. When we know nicotine withdrawal is not the issue, they're still saying, I got, something happened, I got all stressed out, and I went and had a cigarette, and the cigarette reduced my tension. If you think about this in terms of behavioral analysis, if you look at what a person is doing around smoking, for most people, what they're doing is they're stepping away from whatever their moment-to-moment situation is. Say they're at work and they take a smoke break. Well, what do you do if you're at work and you take a smoke break, or in school and take a smoke break? You step away from your situation. You generally go outside. You're outside for about 5 or 10 minutes. You have some ritual that you go through around lighting, getting the cigarette out and lighting it and smoking it. And while you're lighting and smoking your cigarette, what are you doing? You're taking nice, slow, deep breaths away from stressful life. Of course you feel more relaxed. You're practicing relaxation breathing every time you have a cigarette. And so one of the things that perhaps identifying a desirable substitute behavior if a person's trying to stop smoking is don't skip the smoke breaks, just skip the cigarettes. When you feel tension, what I'll generally tell people is when you feel tension, we want to have them have some alternative oral experience. It might be, sometimes I'll tell them to have a glass of water, have a piece of gum, piece of candy, something like this. But I'll tell them while you do that, when you don't skip the smoke break. Take the smoke break, drink a glass of water, take the smoke break in the sense of I'm stepping away from my job or whatever. I'm going outside, preferably to a place where other people are not smoking. But I am stepping away from things. I'm going to have my drink. I'm going to have a piece of candy. And while I'm doing that, I'm going to slow my breathing down. I'm going to practice relaxation breathing, which I think we're going to talk about here in just a minute. And generally speaking, that does the trick as far as smoking being a way of handling stress. And then, of course, the other thing that I just want to make sure I mention about developing a behavior intervention plan is making sure that everybody who is responsible for implementing the behavior intervention plan is on board and understands the rationale. You got to get buy-in. If you don't get buy-in from people, they're not going to implement it. It's got to be, and so when you develop the intervention plan, you need to be asking the people who are responsible for implementing it, is this practical? Do you think you can do this? Do you have suggestions? And the more you can get them involved in developing the plan, in providing recommendations for alternatives, the more likely it is that you're going to get everybody on the same page. So you're going to get some consistency across situations to actually eliminate whatever the problem behavior is. Eliminating this problem behavior, the plan itself, it can include things like making changes to the physical environment, like I talked about in terms of the example of the little boy who had the auditory intolerance of fluorescent lights. It can be changes to the way information is taught or presented. One of the things that we used to have to work with staff about when I was working with adults with with cognitive disabilities is talking to the staff people about what exactly do we mean when we say cognitive disability. If you've got somebody who has an IQ of 60 and their verbal skills, their receptive verbal skills are similar to those of a 4-year-old or a 5-year-old child in terms of the complexity of the vocabulary and the speed of processing, one of the things that we got to teach the staff is you use 1 and 2 syllable words and you speak slowly, and you make and you use repetition. You don't talk the way I talk, a mile a minute. You don't use 4 syllable words, and you don't give multiple step directions. If you've got somebody who's fairly cognitively impaired, you use 1 or 2 step directions, short words, spoken slowly, and repeated. And one of the things you also might do in terms of the way information is or requests are made in that situation is when you get all done, you have the person repeat back to you what you're asking them to do. If you're giving them instructions and you become aware as you're giving them instructions that the kid or the adult, the cognitively disabled adult, is not going to be able to repeat this back, then the odds are that person isn't really going to understand what you're saying to them. Certainly not well enough. They may understand it in the moment, but don't understand it well enough to hold on to it, to retain it, and implement it. So coaching staff, teachers, parents on how to make these changes is a real good idea. Sometimes they involve making changes to the patient's routine. This is things like the smoking, the smoking breaks that I was talking about. Part of the plan, not infrequently, in fact, I would say in most cases, good plans are set up around helping the person in question, whoever the patient is, whoever the person with the problem behavior, helping them to understand why they do what they do, how they feel about it, how they feel about it before, how they feel about it while it's happening, how they feel about it afterwards, to some degree normalizing some of that experience, and empathizing with it, making it, helping the person come to terms with the fact that while this all may be normal that you're feeling this way, it's also problematic, and we got to find a way, and enlisting them. Do you want to find a different way? Generally speaking, presented the right way, buy-in is actually not difficult to get, especially if the person believes you actually are going to be able to produce change. And as much as you're selling it to the person, the patient, the person with the problem behavior, you're also selling the solution to the people around them, again, like I said before. And as you're doing all of this, again, part of the reason for getting very, very specific about the behavior itself and operationalizing it, making it very, very objective, what exactly the behavior is, what exactly the behavior is not, when it's happening, when the context of when it's not happening, all these kinds of things, is so that we can be very, very clear with the patient about what exactly we are expecting behaviorally across situations, across relationships, these sorts of things. Making sure that the patient can repeat it back to us, so we know that they understand. Okay, had to do a quick wardrobe change. Now I took a 24-hour break. That's the nice thing about doing it this way. Okay, so we talked about functional behavioral assessment and some of the ways that we use those assessments. Gave you some examples of some of the situations where that kind of assessment and intervention is effective. I'm going to switch now, and I think for the rest of the lecture, we'll talk a little bit about some other specific interventions that come from behavioral therapy. Although I will say, while these things originated as behavior therapy, or in some cases as cognitive behavior therapy, they're used pretty widely today by people who have all sorts of theoretical orientations. Probably the place to start are the strategies that we use to help foster improved stress management for people. These things are the basis for treatment of anxiety, treatment of PTSD, treatment of phobias, which of course are anxiety related, anger management, these kinds of things. So they're particularly useful. And the nice thing is that they're very simple to teach and fairly easy to implement, although you do have the complicating factor of, how to say this, they seem almost too easy. We're going to be talking, obviously, you can see on the slide there, we're going to talk about simple breathing exercises, and oftentimes, like walking, patients fail to appreciate just how much relief they can get with regular practice of, say, relaxation breathing or walking for a half an hour every day. So the hard part is really motivating people to implement these things. If you can do that, you actually can buy considerable relief from something that takes about 10 minutes to teach. I'll start talking to you in terms of relaxation breathing, because that really is the basis for all the rest of the things that we'll talk about. It's simply a matter of coaching somebody through the process of slowing down and being aware of their breathing. The technique that I generally use with people, because it's so easy to remember, is what we call cubed breathing. And so what I ask them to do is 4 times a day, I want them to take 4 breaths. And each of those breaths, I want them to break into 4 parts. I want them to breathe in through their nose for a count of 4. Hold their breath for a count of 4. Breathe out through their mouth through a count of 4. And sit kind of empty and relaxed for a count of 4. And the explanation with the patient is just that simple. You might provide some background explanation for the patient about why we would expect relaxation breathing to be effective, and primarily we're talking there in terms of kind of shutting off the fight or flight response that's the foundation of anxiety, and helping the body to get more efficient at the parasympathetic nervous system response. You know, you're kind of fostering that calming counter to the arousal associated with the fight or flight response. So you give them, you know, a 5-minute spiel about kind of what the physiological basis for this is, and then what I would do is I would actually model the breathing for them. You know, generally I'll tell them 4 breaths, 4 times a day, in through your nose, hold it, out through your mouth, sit empty, count of 4 on each segment of that, and then I will model it. And you know, I'll tell them, okay, I want you to think in your head as you're doing this, and you breathe in through your nose. You hold it, and you breathe out through your mouth, and then you sit empty and relaxed, and that's 1 breath. And then I tell them you're counting 1, 2, 3, 4, 1, 2, 3, 4, 1, 2, 3, 4, 1, 2, 3, 4, 1. In your head to yourself. And I make sure that they're aware that part of the reason why we're asking them to actually count during the breath is to prevent any sort of rumination or any of the cognitive stuff that's associated with anxiety. And we don't want them thinking about, as they're breathing, oh, I've got to go do this, or oh, I wish I had not done that, things that continue to keep the arousal associated with anxiety going. So we ask them to do the counting as a way of kind of occupying themselves. And as a way, oftentimes people who have anxiety, their respiration rate is faster and shallower. So we're having them count in part to slow all that down. Sometimes also one of the things I'll do, I don't know if you can see it here in the video, but I'll ask them to put their hand on their belly and find a position where they can feel their abdomen as they breathe. And I'm teaching them diaphragmatic breathing. I'm teaching them to breathe with their belly. I always tell, like a baby does. You know, we want you to be breathing like you did when you came into the world. And I have them put their hand on the belly and concentrate on when they take a breath and they fill their lungs, that it moves their hand out. They can feel their belly move out against the waistband of their pants or their belt. It's that simple. We then use that foundation of relaxation breathing to then go and teach them progressive muscle relaxation, which is basically relaxation breathing. And as you breathe in, you tense up a muscle group, and as you breathe out, you relax the muscle group. And sometimes what we'll do is we'll start with something as simple as breathe in through your nose and squeeze your fists, not so hard that you get cramps, but squeeze them firmly. And then as you breathe out through your nose, shake your hands out. That's a good simple place to start in the session with them so they can get a feeling for it. Right, in and out. You can also teach more extensive and complicated, although not tremendously complicated really, techniques where you have somebody actually lay down and progressively start at one end of their body, say with their feet, and they breathe in through their nose and they tighten up the muscles in their feet, and they breathe out through their mouth and they loosen up, they relax their feet, and then they breathe in through their nose and they flex the muscles in the lower parts of their legs and their calves, and then as they breathe out, they relax them, and so on and so forth up the body. Again, coaching them, flex it into firmness, but not so, obviously you don't want them getting cramps. Squeeze the muscle and let it relax as you breathe out. And there are other things you can work into a progressive muscle relaxation process, but that's the basics of it. I have a link here for a YouTube video. There are maybe literally millions of YouTube videos walking you through progressive muscle relaxation, an equal number of them walking you through relaxation breathing. Some of them are really, really cheesy. Some of them are actually pretty good. So I have a list of a few that I'll often give to people to help kind of walk them through it as they're getting used to doing this. The big thing that I emphasize to the patients is, it feels good, it feels nice when you do these things. Doing it once is going to have a limited benefit. Obviously, it does relax you a little bit, but if you really want to maximize the benefit is directly related to how frequently and how consistently you are practicing the technique. If you're practicing the technique multiple times a day, if you're doing the relaxation multiple times a day, relaxation breathing multiple times a day, you can actually produce fairly significant reductions, say, in resting blood pressure over time. You can actually help hypertension, especially if it's stress related, by doing this relaxation breathing. You can change cortisol levels, which has a profound effect on the body, by doing regular progressive muscle relaxation. So these techniques work essentially as well as you are implementing them. You have to implement them frequently and consistently in order for them to really give you the maximum benefit. So once you've helped a patient get a better handle on, learn how to relax their bodies, once you've taught some relaxation breathing and perhaps some progressive muscle relaxation, you can use those techniques in support of a range of other interventions in the course of behavior therapy. They form the basis for what we would call exposure treatments. And exposure treatments are things that we use for treating trauma, PTSD, and things like that, and phobias, as well as OCD, other things like that, particularly OCD, for example, that has to do with hand washing, that sort of thing. If you have somebody who is obsessive compulsive and there's a germ component to it, they're washing their hands excessively, they're highly avoidant, they're compulsively avoidant of germs. Using exposure approaches actually works quite well as long as you're managing the anxiety, and you manage the anxiety reaction using that relaxation breathing. You can also do it with psychotropics. You can also do it by having a physician prescribe an SSRI like Prozac or Zoloft or something like that, which can help with anxiety, or in some cases a shorter acting anxiolytic like hydroxyzine, which is, the brand name is Vistaril, and you can use that. It's kind of similar to Benadryl. It tends to produce a bit of a fairly brief, fairly quickly, it produces some relaxation. So you can use some medicines, you can use breathing techniques, and even progressive muscle relaxation techniques to help the person get a better control over arousal levels, anxiety-related arousal levels in their body. And once you've done that, you can use that ability that the person now has to exert better control over anxiety, particularly over the physiology associated with anxiety, to begin to disconnect anxiety-provoking stimuli. And what I mean by that, say, for example, if you've got somebody, the classic example, you got somebody who is phobic of dogs, you can use a graduated exposure therapy fairly quickly in many cases to deprogram or extinguish that phobia. And essentially it's a very, very simple process. You get them to get very good at relaxation breathing. Once they've practiced relaxation breathing for a while and they're fairly confident in it, you select a starting point. And for some people, a starting point somebody who's afraid of dogs, a starting point might be a picture of a dog or a video of a dog or a stuffed animal of a dog, in truly extreme circumstances. And you'd present, in other cases, it might be a puppy or a small older dog that doesn't, that's not real active and enthusiastic, is more likely to just lay there and be petted. And it might not be that you pet it. It might be that you simply, the patient is in the room and the dog is brought into the room on a leash by somebody and sits across the room from the patient, while the patient focuses on controlling the breathing and inducing a sense of relaxation. And that really is all there is to it. Using that example, person's dog phobic. You have a dog brought into the room, again, preferably a calm dog, as non-threatening as possible, on a leash, 10 feet away from the patient. The dog lays down on the ground, the patient sits there, does his or her breathing, and you're talking to them and getting feedback from them about their subjective sense of anxiety. And as they progress through the breathing and the physiological correlates of anxiety begin to diminish, obviously the breathing slows down, their heart rate slows down. You might even work in a little bit of progressive muscle relaxation to loosen some of the muscles that get tense when you're nervous, bring down the blood pressure, these kinds of things. As that happens, either in that session or in the next session, perhaps you have the dog come a little bit closer and you do the same thing, and then a little bit closer and you do the same thing, until eventually the dog is basically laying at the person's feet. And then the next step, of course, would be to reach out and touch the dog. Maybe just put your hand on the dog while you're taking deep breaths. And so on, progressing as far as you feel like, or the patient feels like he or she needs to proceed. I'll give you an example. When we use this for this basic technique for addressing compulsive germ avoidance, hand washing, that sort of thing associated with OCD. I heard a talk by somebody who is an expert in that area, and she has a very well-established treatment approach that she uses with people who are very, very severely compulsive about germ avoidance, and has a very high graduation rate. The graduation rate involves the people that she's working with going into a bathroom in her office and actually either touching or in some cases licking the toilet seat. Of course, they don't know it, but the toilet seat has been disinfected. But she takes them all the way up through the progression to something so extreme that they're never going to meet anything, almost certainly never going to meet anything in real life, approaching that level of intensity. And in the course of this, it goes from at the beginning, and this can take a while, in the beginning, delaying hand washing until eventually avoiding well, you wouldn't do this right now, obviously, with the virus going on, but in normal circumstances, getting to the point where you're not washing your hands at all throughout a day, even to the point of not showering for several days in a row. It actually is a fairly intense process, and she uses it only with people who are really, really, really severely impacted by this. And it's basically a way of, you're not just extinguishing the behavior, man, you are squashing it out in a way that it'll never come back, hopefully. And like I said, her treatment success is pretty good. So that's the basics of systematic desensitization, or what we call graduated exposure therapy. I forgot that I had this slide here. This is just kind of laying out a lot of what I was just describing to you with my example. I want to make sure I didn't miss anything. Nope. Related to or a version, excuse me, of this graduated exposure, we will sometimes, if the circumstances allow, use actually what we call in vivo or live exposure. There are some things that you cannot do live. You cannot desensitize live. For example, the people that I work with who have PTSD related to combat, obviously you couldn't and wouldn't want to re-expose them to combat as a way of trying to extinguish associated anxiety, partly because you probably would just exacerbate it. So you wouldn't use live exposure treatment to deal with trauma related to something that is quite genuinely threatening, life-threatening, say. What you would use in vivo exposure for are things that you're fairly certain are not actually going to result in trauma. So it might be something like with social anxiety. You know, you spend a good bit of time working on management of anxiety symptoms, relaxation, breathing, and this kind of thing, progressive muscle relaxation. You do some skill teaching, social skill teaching. You do some role playing of social skills, let them practice in session with you. And then you would go into situations, in the case of social anxiety, situations that are easily escapable, situations that you can have a fairly well-established script, something so they have a sense of comfort because they kind of know what they're going to say going into it. This would be something like going to the grocery store with the intention of having a conversation with the person in the checkout lane. And at first, it might be just something as simple as you're standing in the checkout lane, practicing your relaxation breathing, stepping up, handing the stuff to them, and making small talk about nice weather that we're having, kind of thing. All the while, in through the nose, out through the mouth, doing some relaxation breathing. Oftentimes, when something like that if you're taking that sort of an approach and we're practicing an interaction, a live exposure to reduce social anxiety, when it gets done, we'll have the person do some homework where they document, how did it go? What were you thinking? What was going through your mind in terms of how badly something can go? How did it actually go? What would you change about it? These kinds of things. And then we use that homework as a jumping off point in terms of planning the next time we go do it. And we continue to go through that live exposure with very simple tasks, very manageable tasks that they get better and better and better at. And as they get better at them, we introduce more complex tasks. And this can go fairly quickly in some cases, and in other cases it can take quite a long time. So live exposure, real life situation that's anxiety or fear producing, and we're using breathing techniques, psychotropic medicines, and homework assignments to begin to kind of defuse those situations that may be anxiety provoking but are actually relatively limited in actual danger. Similar to these desensitization techniques, although much more intense, and still based on the idea of extinction, is flooding. The nice thing about flooding is it can work fairly quickly. If you were using the dog example, if this would be a matter of taking somebody who's afraid of dogs and taking them over to somebody's house where there's a litter of puppies, that are like 2 weeks old, and walking them in them, sitting them down, and letting the puppies crawl all over them. And of course, you're still having the person do the breathing exercise, but basically you're flooding it. You're putting them in that situation where you know it's going to be safe. You want them to have a strong anxiety reaction, and you want them, one, to work on controlling the anxiety, but also you're wanting to allow the anxiety reaction to kind of run its course, and nothing bad happens, right? The puppies are crawling all over them. They're freaking out. They're stressing out. They're hanging in there. They're doing their breathing. And over time, what happens if you expose yourself to something like this that scares you, but you don't leave the situation, is that gradually the anxiety diminishes. I have a first-person experience with this. I have all my life, or most of my life that I can remember, had been afraid of heights, and largely eliminated that by going and climbing a mountain. It was 12,000 foot mountain. Scared the crap out of me. Spent most of that time with my heart wanting to pound out of its chest. But the reality is, you get to the top of the mountain and your body is freaking out, but you're not dying. And your body is freaking out, but you're not dying. And your body's freaking out, and you're not dying. And eventually your body, which is where all this is, anxiety is so heavily a physiological response, after a while the body stops producing that anxiety response because the feared danger isn't coming to fruition. You're afraid of heights because you're part of your brain, a deep down kind of animal part of your brain, is telling you you're going to die. And the longer you stand there in that high place and don't die, the more you're working toward extinguishing that animal response in your brain. Now, obviously, flooding works only in situations where the anxiety is fundamentally unrealistic. You take and you use flooding in a situation where, say, you'd use it with a dog, and the dog actually, God forbid, bites the person. Well, you just made everything worse. So you need to be very careful about how and when you use this. And the person obviously has to be willing to do it. I mean, right? You wouldn't do this against the patient's will. The patient would have to be ready and willing to give this a shot. And in some cases, you can get them to do it simply by pointing out to them, hey, man, this is a one session sort of a thing. We can fix this today. In some cases, you want to be confident that you're right about that. And you want to have the breathing and the anxiety control fairly well established if possible. I already made reference a few minutes ago when we were talking about social anxiety to the idea of social skills training. Your reaction might be, well, that's just education. Well, yeah, and part of behavior therapy, part of all therapy, can be just simple provision of education. But this social skills training is a very powerful tool. I spoke to you a little bit ago about working with kids with autism. Kids at the higher end of the spectrum, one of the most important things you can possibly do for those kids is walk them through the social skill acquisition that most of us experience unconsciously. We don't, by osmosis, right? We don't have to learn about how to make eye contact. You just know. We don't have to learn about personal space and the bubble. We instinctively know. Well, people on the autism spectrum, I'll give you an example of this. I think I may have given you this example before. One of the classic things that complicates social interactions for people on the autistic spectrum is gaze as a social mediator, right? So we use eye gaze as a way of establishing contact with somebody, as a way of appearing honest and earnest. And people on the autistic spectrum run into two problems. One, because they're not getting kind of just as a matter of course the feedback, and they don't instinctively know how to use the eye gaze as well as somebody as the neurotypical person, as the person who doesn't have an autistic spectrum diagnosis. They tend to, without even knowing it, they tend to kind of move away from using eye gaze, or never establish the eye gaze, and instead do something that's very logical. If the eyes aren't telling me anything, well, what I'm going to do instead of looking at the eyes is I'm going to look logically at where the noise is coming from, the mouth. And of course, the problem with that is that on a mammalian level, certainly on a human level, the message that you're giving by staring at somebody's mouth as they're speaking to you is that you feel some sort of generally sexual attraction for the person. In the case of somebody on the autistic spectrum, that is not at all what is going on in most cases, not at all what's going on. They're just doing the logical thing. The eyes aren't telling me anything. I'll look at where the noise is coming from. And that's a very easy thing to coach. You explain to them how that's, kind of how most people experience that, and you help them understand it. The person doesn't even necessarily know that it creeps them out because it's associated with sexual attraction. They just feel it, and that can be a difficult thing for a person sometimes on the autistic spectrum to understand. But once you can communicate that to them, then you give them the assignment of improving the eye gaze. And that's the second piece of this thing, is that when somebody on the autistic spectrum is given social skills training and they're just told, well, you're supposed to look them in the eye. Well, what you'll often get is this overly intense pupil to pupil gaze where the person with autism almost seems as if they're trying to intimidate the other person. They're giving them a very intense, they're trying really hard to make eye contact with the person, looking directly at their pupils. And so what you have to do is again, because this is not instinctive for them. So social skill training in that case is as it kind of comes from that that behavioral analysis approach of really breaking down behaviors into their component parts and understanding exactly what is going on in those behaviors. What we're doing this with now for the person with autism is we're explaining eye gaze technically shouldn't be called eye gaze. It should be called triangle gaze. And we talked to them about how there's a triangle going across the eyebrows and to the tip of the nose, and that good eye gaze is basically moving your eyes around on the person that you're talking to and looking within that triangle, not staring at the eyes themselves, but looking from the tip of the nose to the edges of the eyebrows in that triangle. And once you coach them that, and they practice it for a little bit, it becomes second nature, especially at the higher end of the spectrum. They get very good at it very quickly, and you don't even know, and they can get so good at it, they don't even know they're doing it anymore. It becomes routine for them. So we use it for people on the autistic spectrum. I already talked about how we use this for people with social anxiety. You can use it in situations where somebody is having marital problems because they're having arguments, in job settings or school settings where you're coaching somebody in terms of conflict resolution. You're teaching them the skills to de-escalate an anxiety or anger-provoking situation. Bullying. There is online the Gracie Jiu-Jitsu. It's a jiu-jitsu program out in California where they actually bring kids who have been badly bullied, and they bully-proof them, and they bully-proof them in part by teaching them to physically take care of themselves. They teach them jiu-jitsu so they can manage if a bully pushes them and a fight ensues, that they can manage themselves. And the reason for doing this isn't so that you can have a good fight. It's because we know that if you have the sense that if something does become physical here, I'm going to be safe, because once a person gets that idea, anxiety diminishes, right? So if you're dealing with a bully, the bully feeds on fear and anxiety. If you can help the person be calm in that situation, relaxation, breathing, and things like that, but also by giving them a sense that I can physically take care of myself, then the anxiety reaction diminishes. But then the other thing that they do at this program, the Gracie Jiu-Jitsu program, bully proofing kids, is they actually teach them social skills to defuse the situation and to be appropriately assertive. And their success rate is really, really high. So social skill teaching across a range of situations, it's remarkably effective and really fairly easy to implement. And the nice thing is you don't have to have a degree in psychology. You don't have to have a doctorate. You don't have to have a license. You can train people to teach this stuff pretty easily. I spent many years teaching people in school systems how to use social skill training with kids who are being bullied, kids on the autistic spectrum, helping teachers defuse intense situations where there had just been a fight or is getting ready to be a fight, these kinds of things. And you do this not just by explaining the situation to them, but by demonstrating the behavior itself and by role-playing it. And normally I would give you an example of this technique. I'm already at an hour and a half, and I've got a couple more slides to go. I want to cut this short, so I'm not gonna go through all of this. The mindfulness and acceptance exclamation point question mark thing you got there on the slide. That is just, I believe in the book. It makes note of the fact that mindfulness and acceptance strategies are part of behavior therapy, and certainly behavior therapists are welcome to use those things, but they are really not behavioral. They're certainly cognitive behavioral. They're very, very effective. I just don't see them as particularly behavioral. So I'm being nitpicky here. I'm not saying not an important technique. It's a very important technique. They work very, very well. In fact, so well that presuming that time allows us, we're still going to go over that acceptance and commitment therapy, I think the last lecture. And we may talk a little bit at that point also about mindfulness approaches. So very, very effective techniques, but not something I would necessarily associate with behavior therapy. I'm not going to say much more about it. They talk about it in the book. I will just make this one note. I'm not going to talk about acceptance work because, again, we're going to come back to that later. I'm not going to talk at any particular length about dialectical behavior therapy other than to say that it is really more a mix of existential and cognitive behavioral techniques that we use for people to work with people who are otherwise very, very difficult to work with, people who are suicidal, people who have borderline personality disorder, in some cases very, very severe PTSD, and alcohol or other, AODA is alcohol or other drug abuse. Those populations, eating disorders, PTSD, AODA, borderline personality disorder, suicidal patients, very, very difficult to work with, very risky to work with. And DBT is a really well-rounded strategy that uses behavioral techniques, cognitive techniques, and existential techniques in individual therapy and group therapy. Good empirical support for it, good anecdotal support for it, does require a fairly high level of expertise and a good bit of training in order to implement it. Again, I don't quite know why it's being presented as behavior therapy, other than it does include behavior therapy. I would definitely see it as more of a cognitive behavioral technique. And I think Marcia Linehan probably would describe herself as a CBT therapist, as a cognitive behavioral therapist. The one last thing that I'll mention regarding mindfulness, again, not particularly behavioral. In fact, I see that as probably the least behavioral of all these things. Mindfulness training, it includes relaxation, breathing techniques, that sort of thing, and teaches some meditation techniques. And it is basically helping people practice and become comfortable with remaining in the moment, of not thinking about what is coming, not thinking about what is in the past. And you can think about it like this: if teaching people how to avoid worrying about what is coming in the future, anxiety, and avoiding regretting what happened in the past, which is often associated with depression. The better you can help people stay in the moment, the more you get reports of reduced symptoms of depression, reduced symptoms of anxiety, and increased sense of contentment and satisfaction. Very effective techniques, fairly easy to teach. It does take a lot of practice to implement them, but the basic kind of foundational stuff associated with mindfulness is pretty straightforward in terms of teaching and practice. It again is just like relaxation breathing. Not complicated, but it only works as effectively as you practice it. If you practice it every day, multiple times a day, within a month or so, you're going to be very good at it and you're going to notice a difference. Lots of material online about mindfulness. I would say go check it out. Again, not particularly behavioral in anything other than some of the components that help you get there. And last slide. just a real quick breakdown of some of the stuff that some of the components of DBT. Again, involves behavioral strategies, but not predominantly behavioral. Definitely CBT incorporates some analytic, existential, and humanistic, because nowadays every therapy approach incorporates humanistic concepts. All right, I'm going to draw this to a close. I will send you an email alerting you that this is up, which will be of no news to you now because you'll have already gotten that by the time you hear me saying this. Very strange. And I'll send you also an email letting you know the details about when the test will be posted. You, by the time you see this, probably will have some experience with taking, if you don't already have some experience with taking a test on Moodle. I understand it's pretty straightforward to take it. It's not necessarily very straightforward to make the test. So wish me luck, or don't. Maybe you don't want me to be able to successfully make the test. I don't know. All right. I will talk to you later.